Good afternoon, and welcome to Planning a Course to Population Health Management, a complimentary webinar from healthsystemcio.com. Just a little housekeeping before we get started. My name is Anthony Guerra. I'm the editor-in-chief of healthsystemcio.com, and I'll be your moderator today. For asking questions, which we encourage, you can type it in at any point in the lower right-hand corner of your screen, the Q&A box, and leave the default set to all panelists. We'll be taking them later in the program, but as I said, go ahead and send them in as they occur to you. You can download the deck at any time. It should be in your Q&A box. It's in front of you, and we have it at the bottom of some of our slides. But go ahead and send me a message in the Q&A box if you need that again. And we will have an archive available of today's event, usually ready within 2 business days. You'll get an email when it's ready, and a separate registration is required. So you see how we're going to spend our time today. We're going to go about 45 minutes. First, we're going to hear from Tressa Springmann, VP and CIO at LifeBridge Health, and then we're going to have a Q&A with Tressa. So without further delay, I want to turn it over to our friend and a good friend and our speaker, Tressa Springmann. Tressa, thanks for joining us.
Thank you, Anthony, and thanks to the audience for joining today. In the next 30 minutes, I'm going to spend time talking about LifeBridge and really talking about some of the perhaps different things that have been going on in the state of Maryland that may or may not be predictive or influential in other areas on population health management. So you'll probably hear some things that are very similar to your own thought and planning and the things that you're having to react to in your own health systems around moving to a model of wellness, and then perhaps some different specific and hopefully a few practical things that we're doing here in Maryland that you might want to consider. So with that, let's see if I can move down here. I have to start with the requisite picture of LifeBridge Health and who we are and where we are. We are in Baltimore, Maryland, and as you can see, statistically, the statistics are in the middle. LifeBridge Health is a broad healthcare organization, and it's really spent the last number of years, rather than purchasing or acquiring hospitals, it has partnered and acquired and developed joint ventures with many other parts of the healthcare continuum. And whether by design or just by opportunity, it's positioned us really well as we start looking at taking care of the folks in our community as they move, if you will, from cradle to grave. So we have a couple of acute care hospitals, and we actually have another acute care hospital that we're really gratefully hoping will join us in the near future, as well as health and fitness centers, a large physician enterprise. We've got post-acute, subacute, and in our commercial division here, we have a number of different other areas of the care continuum. So we've got ambulance company, we have a Medicaid insurance company, we've got 14 urgent care centers, not only across the state, but in some other states that are adjoining Maryland. Again, our acute care facilities, and both relationships and our own organizational entities in post-acute care and end-of-life care. So that's a little bit about LifeBridge Health. If you're from Maryland, lots of times folks either don't know what it means or they assume it's Sinai Hospital, which is our cornerstone large academic organization. But in fact, we're much broader than that. Very similar to many of you, we too have a mission statement, which has gone through some evolution so that it's repurposed to our new direction, which is much more about wellness and about keeping people healthy. And that's a pretty radical change, understanding that in the healthcare environment in the United States today, especially for our acute care organizations, we're really incented for volume, not value. So we've spent a lot of time refocusing our mission statement and try to be very thoughtful about our refocus on the community across our whole continuum and not just from and through the lens of an acute care organization. So many of you may know this, I apologize, but I think it's important to level set. The Accountable Care Act that we're all reacting, responding to, and embracing it at different levels of commitment has some really high-level impacts to all of us. And a number of them are articulated here, probably no surprise to anyone. Much broader range of private insurance, closing some of the prescription holes in reimbursement, a real expansion of coverage, which has a volume impact on all parts of the care continuum, especially our acute care hospitals, and then really starting to set the pace for all of us around pilot or early studies and actions and incentives about how do we move our current industry to value and away from volume, away from this each mentality that really reinforces the ability to generate more revenue based on more visits. And as you transition from volume to value, perhaps many of you have seen slides similar to this. There are a lot of different techniques that might be employed, whether it's bundled payment, value-based purchasing, or the accountable care organization model. And they've got different definition, purpose, and frankly, different change in terms of where we are today in our volume-based reimbursement structure. I've circled the accountable care organization here, or I've boxed it in, because in fact, as many of you know, and I think there's certainly a wave underway moving all of us to considering ACOs, whether with private payers, if you don't already have that in place, or with Medicare. It's a big deal. It's a big change from today. The reward is to reduce the total cost of care, to reduce utilization, to be caring for individuals in the most cost-effective and high-quality and, frankly, convenient place for them to be taken care of. And that's really different from our last 25 years in acute care healthcare. So these accountable care organizations have three real levers to manage cost. This utilization prevention through medical management, right? Taking a look and identifying those really chronic high-risk patients and just intervening everywhere you can to try and get that chronic condition under control. The desire to retain control within your network. Obviously, if you've got someone with a chronic condition who's bouncing around, your ability to help partner them at the right level of care on a more continual basis is a lot easier if you have a broad network and you have the right tools to do that. And then where you don't have the tools to do that, developing relationships with high-quality, low-cost partners that you can count on as part of your ACO. Now I'm going to kind of take a right-hand turn and talk about what's been going on in Maryland. So in Maryland, we are the only state still with a Medicare waiver. What does that mean? That means in Maryland, we aren't getting traditional payments through a DRG insurance company specific charge model or contract model. We, in fact, have a healthcare cost review commission in the state of Maryland that sets our rates. And each hospital is given their rates by this HSCRC organization, and it's an all-payer rate. So that means that for any given procedure that occurs in any given hospital, no matter who the insurer is, the rate that we charge is the same. And that rate takes into account a lot of different things across the state, indigent care, uncompensated care, et cetera. But, the bottom line is that there is this state function that doesn't necessarily exist anywhere else. And for years, and by the way, there have been waivers in other states, but all of the other states have moved to the national model at this point. And in fact, over the last few years, our increase in our own costs in caring for Medicare patients really put our waiver under review. And it was that challenge to the state of Maryland to say, why do you need to be different? Your costs are going up equally, if not higher, than everybody else's for Medicare. So are you sure you want to keep doing this, or can we just move you to the nationalized system? In fact, Maryland decided to take that on as a challenge and went through a process of, quote, modernizing our waiver. And what it really means is taking a very aggressive approach to trying to meet some of Medicare's goals in terms of cost reduction and utilization. And so this basic construct of our new waiver that went into place this year, and as I have on the slide, their state goals, are really encapsulated in these 4 items. The first of which is to limit growth in hospital revenue. So our 2 hospitals in our system this year are now on a global budget. We're on a fixed budget. So this budget is identified and negotiated with the HSCRC, but irrespective of how many people come to our ER or are admitted this year, we are getting a fixed payment for our Medicare patients. In addition, in order to keep our waiver, the state of Maryland has to save $330 million combined in our Medicare spend. We need to reduce our Maryland hospital-acquired conditions, MHACs, by 30%, and we need to reduce our rate of readmissions, which today is higher than the national average. The interesting thing about these items here is these are state goals. So if my own organization hits our objectives for these 4 different areas, but across the state we miss the mark, we will be subject to losing the waiver. So there's some very interesting dynamics that are encouraging a level of coordination, participation, and utilization of state-based assets that you might not otherwise find in order to sustain this modernized waiver for us. So, in general, if we hit the marks after 5 years, we'll be renewed with the Medicare waiver because it'll demonstrate that we were able to keep our Medicare spend down. And if not, we won't. We'll revert to the national system. But as you look at this, you can step away from it and say, wow, our hospitals, at least this year, are now on a global budget as in a capitated environment, and our patient attribution is whoever walks in the door. So very analogous to an ACO, but with an extremely different attribution model. In addition, a real big difference is the only global budget requirement at this point is in hospital revenue. So as you look across the care continuum, there is a sense after 5 years that we'll start broadening this global budget idea across different services. But today, it's only the hospitals, and not all the hospitals, but the majority of the hospitals that are on this global budget model. So it really makes you start thinking about how you're caring for your community in a very different way. So the key aspects of this budget model are a fixed revenue base, age and population adjustments, market share adjustments, and then, of course, just like every other at-risk model, adjustments for quality items like potentially avoidable volume, readmissions, et cetera. One of the things that's really important to note here, at first blush it might sound kind of exciting to just be paid whatever you were paid and be able to reduce volume by getting rid of unnecessary admissions, by really doing a better job managing people in different parts of the care continuum. But the bottom line is that that annual revenue budget that we're given is based on our market share and our prior year volumes. So we've got to manage the heck out of that, quote, bad volume in our hospitals or unnecessary volume. But if we don't backfill it with the right volume, with sick people who need our help, then not only will we lose market share and relevance in the market, but our reimbursement next year will go down because we'll have fewer folks that we're taking care of. So there's this real balancing act. So our waiver really emphasizes and focuses and aligns with this first strategy of the 3 strategies I talked about prior with regard to ACOs. We're really thinking very differently about managing our high-risk population, but with a twist. It's not necessarily as you might think in a traditional Medicare ACO where that patient is attributed to a primary care physician. But as I said, once someone walks in your ER, they're now attributed to you irrespective of their inter or intra-hospital readmissions across the state. our strategy really is based on some pretty simple components evidenced here. You know, really making sure that we're ensuring the right level of service based on acuity, improving access, especially to chronic patients and for preventative care. And then taking a whole different posture on how we interact with our community. It can't just be a tagline anymore. We really have to live connecting with the churches and the community centers and the schools and the associations in our geography to understand and at all costs to educate and help our community manage their care in a very different way. And, you know, all of this has come down on us in the last, 12 to 18 months. So whether or not this use case, if you will, or this Maryland waiver and the pilot ends up demonstrating success or not, it may be predictive as to what some other parts of the country or federally identified opportunities might entail or might be directional for. So again, we need to not only ensure the right level of care and aggressively manage chronic patients, but we also need to do it in a way where we're not blowing out our quality measures. So there's this counterbalance that's the same as everyone in the nation in terms of core measures, but also includes Maryland hospital-acquired conditions, PQIs, and then this whole readmission struggle, which is actually quite a struggle in the state of Maryland. So for us, one of our other strategies here at the bottom is building our centers of excellence, and that is really what I would call our backfill strategy to our hospitals, because hopefully as we're doing a better job in managing people in a more appropriate level of care than in our ER or in an inpatient setting, if we don't create an ability, and our centers of excellence here are cancer, brain and spine, cardiovascular, an eye institute, and a very broad and deep orthopedic center. You know, we've got to get backfill or as I said, we're going to lose revenue, lose relevance, and, we need to balance that out. This is an example of the state-level scorecard that's being used. And again, HSCRC is Maryland's Hospital Cost Review Commission. And as I said, this is just a really 30,000-foot level across the state at what our goals are and how we're doing. And as you can tell, we're really struggling with our readmission rate. And for us, and this is compared to the rest of the nation, it is all-cause, and we do measure both inter- and intra-hospital readmissions. Here at LifeBridge, and again, probably similar to your own organizations, it has just catalyzed an explosion of new initiatives. And some days they don't feel highly orchestrated or organized in combination with each other. These just represent some of the efforts, not only in our inpatient setting, but in our end-of-life, our chronic care, our urgent care setting, that we either are or will be putting into place to help us respond to this, Medicare waiver mandate and our new orientation to wellness. At urgent care, for example, we are building with our urgent care partner urgent care sites right next to our ER on all our hospital campuses, just as an example of one of our efforts. Here's some others. And again, some of these are pretty analogous to the traditional things that you're going to find in a population health discussion. I'm certainly no expert on population health, so I need to kind of set the stage there. But I think for those of us who've been keeping a keen eye to the market and to the toolkits and to the evolution of the vendors who all now have something in the population health space to sell, we recognize as information systems leaders in healthcare that we need a tool for data exchange to start taking advantage of these standards and an ability to have visibility across our organization for any given patient, a longitudinal record, if you will. We know we need these clinical registries to help us measure quality and to understand where we need to target improvements in order to meet measures of either, for us, the Medicare goals, or for an MSSP ACO for some of the care conditions. We all realize that analytics is an exploding area that's just really multi-threaded, multifactorial, and sounds easy, but not something you just pull off the shelf and plug in. And then obviously, and represented here too, you know, that care coordination and that care management, not just focused on the acute care setting, but over time really being able to have visibility across the whole continuum of care if you're going to manage down readmission and really do right by the population you're serving. So again, this really is just an inventory of some of our projects. None of these are IT projects, but as many of you know, if you're endeavoring towards alignment of your IT function with your organizational strategy, probably every single thing on this list has got a technology implication. Maybe not core and center to its success, but certainly either around measurement or workflow support. Because the state is embarking upon this solution together in managing our Medicare costs down and taking care of the folks in the state in a different manner, it really shines a light on the value and the ability and some of the more practical things that we're taking advantage of that I wanted to cover today, because they may or may not have relevance in your area, but they certainly are going to be very advantageous to us here in Maryland that our state HIE is providing us. So CRISP, the Chesapeake Regional Information System for our patients, is Maryland's HIE, and it is a designated statewide health information exchange. All of the hospitals in Maryland participate in CRISP, and over the past handful of years, we've stood up real-time HL7 interfaces with CRISP to contribute not only patient demographic and ADT information from our hospitals, but also clinical transactions. The state and CRISP have also connected our radiology, our big radiology providers for their results, as well as Quest and LabCorp, our large labs that are used in the state. What we are lacking today but have a strategy for is really data consumption or exchange with our ambulatory practices. And as you know, as I know, 80% of healthcare is really provided at the practice level. So that's a big gap, and that's something we're going to have to tackle. And many of us, probably similar to many of you, are doing that on behalf of population health at a more local level. But CRISP and this ability to house and have patient information from every hospital here has been really identified to be invaluable as we embark upon managing the hospital spend down. So I'm going to talk about 3 different use cases and technologies that many of us are working with CRISP on to help the hospitals support our global budget. And I'm hoping they might give you an idea or two of how perhaps to take advantage of something similar or approach a problem you're trying to solve in a similar manner, because this doesn't really need to occur at a state level. It can occur within your own organization. The first is around managing high utilizers. The second is around these PAUs, really trying to manage down utilization that isn't required by having information available. And then finally, a few CRISP available concepts and tools that today, are helping us in the state with care coordination. So as I mentioned, we're all providing HL7 data, and as a result, with every hospital providing this, and largely, if you will, with an across-the-state enterprise master patient index, we've got a pretty good idea of where admissions are occurring and readmissions, and that becomes very, very valuable. as we look at high utilizers, and this is just an example for one of our own hospitals here, but it's something if you're endeavoring to manage a population, you know, you always try to stratify your patient activity, your visits and your charges. And, you know, here you can see, if you look to the right, that we've got 394 users or patients of our over 81,000 that are driving $47 million of cost. So this information helps you start narrowing down where you can find opportunities, not just in running the health system more effectively, but as a reminder in really trying to improve the quality, the life quality of these people who, you know, perhaps have been to your own ER 40 times over the past year. I know this is a little hard to read, and I'm sorry, and there's some areas that have been blocked out, but let me orient you to this sample report. This is a report available through our state HIE, and it has by medical record down the left-hand column, zip code and age, an ability by patient, of course with some anonymity that allows you to look up the individual, but all of the information on the left-hand side of the gray line is this patient's activity in my hospital. And all of the information on the other side of the gray line is information for this same patient across the state. So you can see, for example, that the very first patient there was an inpatient in our organization 18 times and had 7 ER visits over the time period in question, but they in fact had 12 other episodes of care, whether inpatient ER or outpatient, in other organizations in the state. And you can see there's charges associated with that, et cetera. That pretty interesting and very important information. If you go down to about the middle of the slide, you can see that we have a patient who's seen us 20 times in our inpatient and ER settings, but in fact, which, you know, doesn't make our top 5 list, but if you look at their activity elsewhere, they're a high-risk patient and very potentially need to have a different level of care coordination, not only so that our organizations can do a better job by this patient, but the state as a whole. Now, I do want to point out that this charge information here this is all examples, so it may not make sense to you. I just used it by way of example. But our cost review commission, the reason they're able to set our rates is because we're also letting them know what our charging activity is. And our charging activity gets married back to our patient identity through CRISP. So now we have the ability not only to see this patient movement, but to understand across the state the cost of that movement as patients bounce around when their care is uncontrolled. So kind of important when you start thinking about readmission, and a very invaluable tool for us. This next slide reflects something similar, variation on a theme. You'll see it's inpatient hospital utilization. The thing to notice about these rows is that you can understand what's your readmission rate, both inter and intra-hospital, because again, CRISP has an enterprise MPI, and so they can help us understand who's coming back to us, but they can also help us understand if we're creating a problem for others in the state due to inter-hospital type of readmission rates. From a care coordination perspective, you know, we all recognize that the heart of effective care coordination is visibility across a continuum. And although we'd all like to think everything could be in a single EMR at some point in time and are endeavoring to really deeply implement EMRs in all the care settings, that's just not the case today. And as we work towards standards, there still needs to be some visibility to this. One of the perhaps more simple things that we're about to go live on here in our organization that we hope will be valuable is to integrate our own electronic medical record at our hospital and in our physician practices with information at the state and with the HIE CRISP. if you look down at the bottom of the left-hand navigation bar here, you see something called our CRISP link. And if a user clicks on that, a window opens, and through sharing some context without the user having to log in again or pick the patient again, if there is visit information or labs or radiology data already resident with the state HIE, it'll be visible to the care provider here. So again, it doesn't necessarily give you that completely longitudinal view because ambulatory data is missing at the state, but it does give our clinicians a pretty good snapshot and potentially access to information that might otherwise translate into the reordering of another test. Encounter notification has been a really interesting twist for us, and let me explain this. This ENS allows us to receive notifications based on ADT transaction data. So there are a lot of words on this slide, but let me kind of give you a use case. We have some practices in our system that are NCQA Level 3 patient-centered medical home or are part of an MSSP ACO. And it's really important that they're on top of where their patient cohorts are going, and as many of you know, have a very different level of care coordination. Well, with ENS, we can provide on a monthly basis an updated patient profile to the state HIE, and they keep a hold of that profile, and if any ADT transactions arrive at CRISP and are identified and bounced off of that profile as being a member of that profile list, then a notification is sent to the provider of the profile. So our practice who's provided the profile has a secure mailbox, and they get real-time transactions when their patients show up at various hospitals throughout the state. And again, that visibility has been really, really helpful in trying to reduce readmissions and to really intervene, knowing that they just arrived in the hospital and having some ability to influence the stay and then the transition of care from the acute care setting. There are other use cases for this that have been pretty interesting too. You know, CRISP has all our ADT transactions, so one of the things that we're piloting is for them to hold, kind of in memory, if you will, a running log of who's left our hospital in the last 30 days so that we can in real time know who may have just popped up here or at another hospital in the state. Unlike the report, this is much more in real time. So this is a pretty traditional set of pop health tools for those of us that are embarking upon this. I shouldn't say traditional. I mean, it's all pretty new information for us. So as it evolves and matures, I think many of us have had exposure to different tools and approaches based on our own philosophy and or tactics around population health. But I'm going to start up here at like 1 o'clock. First, you have to attribute your population. Who am I taking care of, and how can I connect them to me and identify them? And then the whole risk modeling, care planning, making sure you're using standards that are evidence-based, this whole care coordination. And I haven't today, but it's certainly a huge topic, talked about using technology around patient engagement to help people do a better job managing their own chronic conditions, and then certainly reporting and performance tracking. So I apologize if you're hoping for me to go into depth on all of these today. I know I didn't, but my real intent was just to talk about some of the things that the Maryland Waiver and our state HIE are allowing us to purpose that really do fit into this same toolkit, but perhaps in a different way. In addition, we're pursuing the traditional population health trajectory. We've picked a partner and we'll be implementing a registry tool and an internal HIE, especially because of, as I've shown you, we've got a real diversity across our system of subacute, post-acute, ambulatory, urgent care, and CRISP obviously doesn't offer any visibility to that. We too have applied and have been accepted and are beginning the journey on the MSSP ACO process for our own organization, and this is just kind of our more generic trajectory of the tools that perhaps you've already have employed or are anticipating for your own organization. Anthony asked me to talk a little bit about the role of the CIO, and again, I wish I had time really to hear and learn from each of you, because it's these type of situations and opportunities where we can understand some of the neat things that our peers are doing, as opposed to being so overwhelmed by what the market is selling. But really, as I've looked back on the past couple of years, I feel as though connect, collaborate, and control really distill down some of the differentiators in this super quickly moving space. You know, first of all, we've got to connect with others. And I really meant this targeted to my own organization. We're at a time right now where we're a little schizophrenic and disorganized on all the directions we're running, whether it's our self-insured employee health plan, whether it's our MSSP ACO, whether it's meaningful use or PQRS or the Maryland waiver mandate. I mean, there are all these different swim lanes of activity, and you know they're all trickling down to us, right? So hiding in the department doesn't make them go away, and really connecting and understanding the organizational appetite and priorities around those are super important, and largely you can only get that by FaceTime. And then collaborating. I'm very engaged with our state HIE, which helps me understand what they're planning, what they're thinking, how we might take advantage of it or not, and then what I may need to go invest in for ourselves and for our own organizations. And then probably the hardest, at least for me, and again, would welcome any insight from others if you're willing after today's call, is trying to demonstrate leadership in a time where I know my department feels as though everything's a priority, so nothing's important. And, you know, that's just a daily call to action to provide that leadership of when there's readiness on any one of these different tactics, readiness enough to start communicating and translating and investing. So that's, you know, again, this is just Tressa's perspective on the things that I've employed in the past couple of years to manage some of this churn down. I think in conclusion, probably there aren't many folks on the call who feel that the acute care organization will be what it's been in the past. And in fact, what is running under the waterline to influence that is massive. And we'll all be very involved in that. It's kind of exciting. It's going to very much redefine where we as CIOs focus our time and attention and what technologies we employ. And of course, certainly where we don't want to land are giving patients choices or having them make poor choices about taking care of their own care. So not much for comics, but I thought I'd try and end this on a light note. So with that, Anthony, I'll turn it back to you.
Excellent. Well, that was an absolutely wonderful presentation, and looking forward to our Q&A. We already have a number of questions that have come in. So just as a reminder, go ahead and send your questions in. We have a few minutes to get them in front of Tressa. Send them in the Q&A box and leave it default set to all panelists. Okay, first question, does the global budget reflect the $330 million savings, or are the savings on top of the official budget?
Yes. So, you know, in all honesty, there hasn't been complete visibility on how the top line number will be met by any individual organization. But when the broad stroke delivery of the information and the budget has been conveyed, absolutely there's a scale that builds that savings in across those 5 years based on the assumption of reduced Medicare volume in our hospitals. So it is built in there, but it's not as transparent that we can see how many dollars and how many patients are kind of earmarked from one hospital versus another.
Very good. Next question. Would you describe your physician community, employed versus independent, group versus independent practice, et cetera?
Yeah, that's a great question, and it's a big challenge for us. You know, we've got an academic medical center with a you know, pretty traditional faculty. We also have community setting. We have probably 450 employed physicians, a couple hundred of whom are out in the community. And philosophically, our relationship with our employed physicians was what we would call aligned autonomy. And that's made it a bit of a challenge from an IT perspective, because the model we did not embrace was that when you become employed, you're going to use all of our stuff. They actually are on a revenue minus expense model, except for the faculty. So if our systems infrastructure isn't providing a cost-effective solution for them, then they're really disincented to sharing in with some of our technology, and that's why standardization and an HIE tool are pretty critical. We've just stood up a PHO, LifeBridge Physician Partners, which is going to be incredibly invaluable for helping us set our care standardization apart from the hospital, right? Many of us began on that journey as we implemented automation in our hospital settings, but really taking a care condition and having clinicians from across the enterprise at the table defining what a best practice should be is tough enough, and then translating that into 45 different electronic medical record systems remains a bit of a mystery, but we'll get there.
Very good. Question for clarity, does CRISP retain the information in a centralized location, or do they query upon a patient presenting at a hospital?
Yes, both. So there are parts of the technology stack, like the MPI, that are managed centrally for all the reasons that make sense to us, right? But there are other components that are, I'd consider them much more a query response type of approach. It depends. Actually, CRISP has a lot of different applications that it's now making available to benefit us. And but what I can tell you is it's not a massive central store of the information that we've been feeding them over 3 years.
Okay. Is CRISP funded by the state or by its member institutions?
CRISP was founded by a handful of organizations who really recognize this inability to share data and this frustration with everybody trying to solve the problem on their own. And it included, I'll probably get the institutions wrong, so I'm not going to repeat them, but a number of the large hospital systems, well known here in Maryland, and a long-term care community. And when the state recognized the value, the governor asked all of, and you know, when a governor asks, that's kind of a nice way of saying we were all expected to participate to provide the value that we know that we could. So initially, the hospitals paid a subscription fee. And although we continue to pay a fee, and there is an expectation of contribution on the part of all the hospitals, CRISP has gotten state funding, and it's gotten cost review funding, and it's gotten some very creative. They've been very good about trying to get grant funding based on some of the things that we can now do and to allow us to hold down the cost. Obviously, there are other aspects of the HIE. Our physicians here in the state can use a query portal to look at all this healthcare activity. And the providers themselves, the specific physicians themselves, don't pay a subscription fee.
Very good. We have about time for one more question. I just wanted to ask you, it seems like to accomplish many of the things that you're being asked to accomplish from the federal government, from the state, and in every other which way when you go into ACOs, it require very, very large investments in technology. So as you're trying to save money, you're required to spend money. Do you find that your institution is open to giving you what you need from a budgetary point of view? And give your CIO colleagues who might be listening any advice you can give on those discussions about, hey, yeah, we need tools to do these things. I'm happy to go out and investigate them, but it's going to cost money.
I'm actually having the reverse challenge, which is we're in a different era. You know, a lot of these things you can't just pull off a shelf. It's very situational, depending upon what your own strategies and tactics are. And for any of you who've looked out at, you know, give me a common definition of what a population health tool set is. I mean, even that can be debatable as the definition for that matures, and whether or not you're going for, I mean, now we've got best of breed pop health as opposed to integrated from EMR vendors or integrated from non-EMR vendors. So it's taking on a life of its own. You know, Anthony, the challenge that I face is that there is this kind of expectation that, like an EMR or a revenue cycle system, I can just kind of go out and plug one of these things off a shelf and satisfy all the requirements of population health as my own organization has defined it. I mean, we're in a really, really rapidly moving growth period for what this even is and what it does. I'm very fortunate, you know, LifeBridge Health, because of its wise investments in this commercial division, which has the ability to bring additional revenue into our own organization. Money's not the issue. The issue is really kind of the burden upon me to make sure that we aren't wasting money on technology tools that either aren't where they need to be from a maturity perspective or aren't exactly what we need to facilitate or support our own strategy. So the actual money itself, that conversation hasn't been the problem. The problem has been trying to manage the expectation around a silver bullet that doesn't exist.
That's an absolutely excellent answer and a great point that it'd be great if it was sitting on the shelf and just coming up with the price tag was the money for the price tag was the issue, but it's not that easy. So with that, I want to thank you so much. Excellent, excellent presentation, Tressa. We appreciate your participation. For our attendees, as I mentioned, you'll receive an email when our archive recording is ready, usually within 2 business days, if not sooner. Separate registration is required. For those of you who have the CHIME CIO certification, attending our webinars gets you 1 CEU for each event attended. And so go ahead and let CHIME know you attended, and if you've asked us to do that, we certainly will. Questions, comments, you can always reach out to me, and you can go to our website to view our upcoming schedule and our last 12 months of archived events. So with that, I want to thank Tressa, I want to thank our attendees, and everybody have a wonderful day.